Hey, it's Dr. Bill with just the tip of urology school, and we're talking about some radiographs, some surveillance for management, and many urologic issues. When do we use contrast, whether it's intravenous or through percutaneous placed tubes or through Foley catheters and SP tubes? Basically, remember a KUB is a plain film without any way of showing function of the kidneys, ureter, or bladder. We're basically assessing radiopaque stones, which is about 90% of stones. It's important to see if there's any progress from previous surgical manipulation to see if there's stones there. If there's stones that are there, are they growing? And this is a pretty easy way of following patients. We can also assure ourselves that there is appropriate placement of percutaneously placed tubes or ureteral stents that may be utilized. When we talk about the use of contrast, we can use contrast via Foley and SP tube, via nephrostomy tube to look for patency, rule out leaks from previous trauma or previous surgical repairs. When we talk about the intravenous use of different forms of contrast, whether it's an MRI, CT, or intravenous pyelogram, we're looking to define anatomy. We're looking to define any anatomic or congenital abnormalities. Presence of two functioning renal units would certainly be appropriate after certain surgical repairs, and certainly necessary when we talk about trauma that's going to require some sort of surgical exploration and repair. We can use retrograde pylographic studies under anesthesia when we are looking to define the character of the ureter, looking to see if there's presence of any obstructive pattern or any abnormalities that may be a function of stones or urothelial cancers. Remember that when we talk about bladder cancer, upper tract surveillance periodically, including the ureters and the renal collecting system, is very important. We can use this in people who have severe renal dysfunction or people who have severe contrast allergies. When we're talking about intravenous use of iodine, for instance, that contrast allergies are always a concern. Even if you're not going the intravenous route, if you use previously placed catheters and utilize iodine contrast in a non-intravenous pathway, you can still, under back pressure, have the iodine exposed to the vascular system and precipitate the potential of an IV contrast. So it's rare, it can occur. And so when we're talking about having a comfort level in ordering these tests, especially in a situation where you may be administering intravenous contrast on site and you're around, not everyone is ACLS certified, but we should have an idea of what can occur with an iodine contrast allergy. We certainly have those pathways and algorithms on record in our radiology department. It's nicely outlined in the AUA 4 curriculum, and utilizing your up-to-date apps will give you some insight in how to work with these patients. It may be a simple rash or some swelling of the lips or the throat, difficulty breathing, and severe hypotension. Sometimes pills like Benadryl or antihistamines can be utilized. Oftentimes, we are asked to start an IV for support of blood pressure and maybe utilizing medications like epinephrine for cardiovascular support. There's a nice algorithm that's available to all of us. If you're going to order these tests, be comfortable in dealing with the rare but very, very significant potential of having a contrast allergy. When you're utilizing non-iodinated contrast material that is utilized in MRIs, not so much of an issue of an allergic reaction necessarily, but there can be concerns of significant and irreversible renal dysfunction. So be aware of these concerns, read about it, talk to your MD practitioner, a supervisor if necessary, and always, always ask for support. Remember, in these kinds of issues, it is an absolute team effort to get your patients home safely off the table. Dr. Bill, with just the tip of urology school, talking about contrast material and radiographs in utilizing various types of diagnostics for intervention and for diagnostics.